Talks on the End of Life, a series of public forums on how to handle the challenges of aging and the final days. The conclusion of our series, Death, Dying, and Ethics, a Pediatric Perspective. Sponsored by St. Barnabas Episcopal Church with Hospice of Cincinnati.
I've been at Children's Hospital for about going on 24 years. And so I'm going to combine in this presentation two areas that are related, certainly in my experience as well as I think actually. So I'm going to talk some about children's understanding of death because I think it's different. One of our mantras at Children's Hospitals is that children are not little adults. So they're at a different stage developmentally, they think differently, they take in reality differently, and so it's helpful to know how they think about things as significant as death and dying. And it may not be that any of you will have a direct opportunity to use this, but you may know people who are going through a time with a child and also with their siblings where at least the possibility of death is there, and this may help you in knowing how to help them. So I'm going to take the information about children's understanding of death in sort of age categories. And I want to emphasize at the outset, first of all, that the categories are a little bit indefinite because, as you probably can understand, children don't just develop in sort of lockstep, and every child is at the same stage at every age. These are approximate. And children's attitudes and understanding about death will vary in their meaning depending on their age and their understanding. And so in a very general way, and this is something that all of us who work in this field learn pretty quickly, in working with children around any kind of difficult illness issue, whether it's the fact that they have an illness or that they've been seriously injured, or up until the possibility of dealing with death, it's really important to try to understand what their questions and concerns really are about, and not to assume that the words that they're saying translate into adult terms. So, for example, a young child, 3, 4, 5, 6, may ask the question, am I dying? Now, if you or I were to ask that question, we would most likely be looking for initially a concrete response. You want to know, you think you may be, and you want to converse about that. But a little child may be asking that question not because that's what they're looking for, but their question may have more to do with something like, am I safe? Or will someone take care of me? Because the idea of death and the finality of it they aren't capable of taking all of that in. So we need to understand what's the question behind the question when they start talking about these things. And in a general way, it's very important to know that, especially with younger children, taking care of their emotional needs is more important than dealing or trying to figure out their cognitive understanding about the realities of death. Does that all make sense? Okay. So if we take the group newborn age to 3, I think, there we go. Of course, newborns will have no concept of that because they have no concept of self. But somewhere along the way, as children become more self-aware, if they have any understanding about death at all, particularly for themselves, it is really going to be defined as an absence of love objects. It's really not, they can't conceive of themselves going away. If to the degree they think about it at all, they're imagining that everybody else will leave them. And that's why questions of safety can be so important. So really, the theme for children at this age is more one of abandonment. And so they need that kind of reassurance. And if they say it's a sibling, a young sibling, and they're anticipating the death of a loved one, whether it's a sibling or a parent or a close relative, what they are primarily sensitive to is a change in the environment. Changes in household routines as people come and go and readjust their lives. Suddenly one or the other parent may just be absent at times, odd times, when they were always normally there. And so their response to these kind of emotional changes are not surprising. It'll often cause them to change their own patterns of behavior. I mean, you can even see this in a more benign way. If you have a child that's just been toilet trained, and then you bring another baby into the environment, sometimes we see that child regress, suddenly as if they haven't learned anything, because this is how they're dealing with this kind of stressful event. Well, it's the same kind of thing when children are trying to respond to the changes around them that seem to have a lot of emotional content. And so while they cannot really comprehend death, they can comprehend sadness and other significant feelings. They can take all of that in, and so we need to be sensitive to that. So if we move then to ages 3 to 5, a child at this age may have had some experience of death. They may have had their pet run over or gone to the vet to be put down. But sometimes the kinds of deaths that they see, like roadkill and that sort of thing, it's accompanied by mutilation, and so that may figure into how they think about death. That it's something awful that happens to the body. One of the reasons that that's important, for example, in the hospital, is we have a wonderful department called the Child Life Department. And one of the things that they do is for every child who is facing surgery, they will go and prepare that child with dolls. And they will do to the doll what's going to be done to them so that they can understand it. They'll put bandages on and they'll put a tube down the throat and do all this thing just to help them normalize it so that it seems less scary. The other thing is that children of this age tend to think of death as temporary. And why not? How many cartoons do they watch where somebody falls off a cliff and gets squashed and then bounces back? So it's very hard for them to comprehend it's hard enough for us sometimes to comprehend the permanency of it. Certainly can be hard for little children. But also the other thing to be aware of at this age is it's the wonderful age of magical thinking. Now that can have delightful aspects to it because of their capacity for fantasy and imagination and play and fun. However, it also manifests itself in this kind of an odd sense of being responsible for something that you're not responsible for. So depending on the emotional quality of the household, they can imagine that if they're dying, that they're being punished for something that they did. And likewise, if they're anticipating the death of others, it's still temporary. I mean, again, you've got Jesus and Lazarus and a lot of stories that might support that. And the magical thinking takes place in the sense of how many of the older siblings have wished the younger sibling dead, right? We all get that. Well, now they are. So I must have caused that. So, for example, when we're dealing with an older sibling of a child that's had done it, like we've had a SIDS death, which we have, unfortunately, all too often at the hospital, it's really important to take the children aside and say, this is not your fault. This is just something that happened. The other thing that happens at this age is that children are very good at making connections. It's sort of the concrete operational stage of development. And so one death can imply another, so that the conditions that apply to this death are applied to others. So you say, well, why did grandma die? Well, she was old. Well, Mom, you're old, Or, well, your brother got sick and he just got sick enough and he died. Well, the next time I feel sick, I can get very scared that that's what's going to happen. So it's really important to explain differences in circumstances between old and really old, for example, sick and very sick, and assure children of lack of blame, and normalize their feelings, which is not always easy for us to do if we're uncomfortable with them ourselves, but to normalize our feelings, their feelings, is very important. This is a normal way to feel. You're sad, you're angry, you're confused, whatever that is, that's part of the picture. and to tell them and hopefully show them that over time it can get better. So from 5 to 7, child begins to develop a personified concept of death. You know, the boogeyman and the ghosts are coming to get him or her, but they also begin to understand that death is really permanent. And that's also true as they contemplate the death of others. And they also have this sense of death as the taker. And we certainly have images of that, you know, the guy with the scythe and the whole thing. Something that comes and gets you, or it could be something that you catch like a cold. And they may associate it with a place, so they may not want to enter a house where someone has died because death dwells there. And death may also, because of just their entertainment experiences, be associated with violence. So there may be a question about, well, who killed this person? Again, all these things, we need to be aware of them. And the approaches really have to do with the need for presence, especially if the child is dying, need for more detailed explanations of why someone is dying or why they have died, and the normalization of feelings, and sharing your own. It's so helpful for children to have their parents and other significant adults be able to say, this makes me very sad. Yeah, I'm really going to miss this person. It helps them feel that they're not alone in their feelings and can help form a bond. Now, what you want to guard against is just as any caretaker does, when you're dealing with a child and trying to help them through it, then you don't make it all about you and your feelings. If I'm with a family and we're in the middle of a death, I'm perfectly comfortable with shedding a few tears with them if I've known the person and I'm feeling some sadness at the loss. But I sure don't want to start breaking down and start sobbing and then suddenly go, oh, they got to take care of the chaplain over here. That's not real helpful. And it's the same thing when dealing with children. It's very helpful for them to know that you're sad and to see some evidence of that. But try to remember that in that moment, at least, the focus is really on them. Okay, and then we go from ages 8 to 11. And so we're getting more and more into a normal concept. They're death is more and more permanent. They have more of an adult concept of death. They can begin to use symbolic and language and ideas to express their needs and their fears. This is an age at which religious training can really make its mark, depending on what they've been taught. What are they being taught at home and in the church? You know, if they are getting very strong messages about heaven and hell, each one being a very likely possibility, they're going to worry about that. And that kind of stuff may really influence how they think about their own dying. It is not an uncommon conversation to have with a child at this age if they at least have the anxiety that they may be dying or they're very sick and they're very worried about their soul and their salvation. And it takes a lot of sensitive conversation to help them deal with that. And because what they sure don't want to do is go to hell. And they may have heard a lot of language around that. It's also much more difficult for children at this age to be in denial, at least a childlike denial. Again, all of us can stay into denial, right up to the end, and I've certainly seen that happen. But the kind of the magical stuff has gone away, and they're more likely to acknowledge the reality. So. Also, if they're dealing with the death of another one, then again, they have a more realistic understanding about the impact of the death. They are more able to understand disruption and loss, and partly because we can explain it to them. This is why mommy has to go to the hospital. This is why dad's not around so much, because he has to go and take care of so-and-so. And their feelings are going to be closer to adult feelings. So what's very important here, particularly from a faith perspective, is to try to locate the event in the context of the faith that you espouse. I can't think of a more important time in one's life that for us to be able to speak about what our faith means to us in the face of death, how we approach it, and what we think the meaning of death is. And this is therefore a very helpful time. Of course, I say that with the hope that your faith issues around death are healthy and productive, because I've certainly seen the opposite. But it's a time when the children can begin to more fully participate in the faith life of the family and the church and get some meaning out of that. And there's more of an ability for them to be able to discuss the implications of the death, about what the changes in the household are going to mean, and whose roles are going to change, and that kind of thing. So the last category would be generally that of adolescence. And I just, very simple thing to say about that. Adolescence, probably 15 to 18, 14, somewhere in that age range. They could be sitting here in this room and feel like they're pretty well understanding what I'm talking about. Cognitively, they are there. They understand death, they understand disease, they understand accidents. They can talk about all of that. They can even talk about their faith and what their faith has taught them about it. But just because they talk the talk doesn't mean that emotionally they are in the same place as an adult. And that's often the trap that some of us can fall into. They seem so put together about it, or they seem so thoughtful about it, but developmentally their emotional life is still in some turmoil just because they're teenagers. I remember being a teenager, and my emotional life was constantly in turmoil. Imagine most of yours were too. And so something like this goes on, and outwardly they look fine, but inwardly it's still a very upsetting event, and they are not necessarily dealing with it as well as we might like. And so the problem is that gets enhanced by they tend to be reluctant to talk about it, especially with adults, right? Because we don't understand. So it's important for them to have trusted people that they can go and talk with and know how to listen and know how to help them work through it. Okay, so let me stop there just to see quickly if you have any questions about that material. Yes, John?
In either of those groups, say age 5 to 7 or up to 11 or 12, this may sound like an odd question, but there's, I guess, a point to it. In your experience, do these kids seem to have more trouble confronting their own death, or if it's somebody else who's dying, are they more worried about the aftermath? In other words, what happens to me? What happens to the family? Who's going to care for me?
That's a good question. I think, I wish I had some of my colleagues here because among us we have a vast array of experience. Kids in terms of approaching their own death, I find, I think they can deal with that in some ways better than the death of someone else. Especially if there's time for them to do that, if they've been living with a chronic illness, a cancer or heart disease or other kinds of things, then I think they do a remarkable job of incorporating that into their self-awareness and really evidence a desire to know and participate as best they can. Then when it comes to somebody else, they can have a very hard time. The thought of losing that person, any unresolved stuff that goes on with that, that can be much more difficult. Yeah.
How about a little kid in the inner city area of Cincinnati?
My general experience is that it's hard no matter what.
Okay.
Maybe older teenagers, they get calloused about it, but I think younger children, it's a shock, and it's not what they expect. Because that's just not, even if they see it, it's just not something they take in very readily. And I can't speak to that 100%, but I just thinking about the siblings that I've seen, the younger siblings, they're lost, and they're really having a hard time. So having given you that background, I want to talk about death from an ethical perspective. One of the roles I have, I'm the chair of the bioethics committee at Children's Hospital, And we do a lot of consulting with staff around a number of issues, including issues that relate to death and dying, end-of-life decisions for children. And it's a kind of a challenging area, and I'll say more about that in a minute. But let me just say for a minute, the question is, why do we do ethics? Ethics, bioethics, hospital ethics, clinical ethics is really still a relatively new field. When I came here in 1990, the Children's Hospital had just developed their own ethics committee, and the hospital I left in Connecticut was beginning to start one. This was all pretty new in most institutions. And part of the reason was there was always a lot of resistance on the part, particularly of the medical leaders, about why do we need to do ethics? We are ethical people. We know what the right and wrong is. And the reason that we do ethics, from my perspective, bottom line, is that the critical points of life evoke in us our own value system. And I bet if I could stop this lecture right now and I could administer some kind of a values quiz around some particular issues, we would be at various places. We would not all have the same values around some of these critical things. That's pretty much a given. It has to do with how we've been raised, what we think about, what our life experiences have been, how we understand our faith, a whole bunch of things. So, because our values differ, the way that we approach critical situations will therefore differ. How we think about them will differ. And it's not a matter of right and wrong, even though it sometimes feels that way. Why don't you see just how wrong you are? It's got to be this way. The abortion debate would be a really great example of that, where it tends to get very dichotomized, good, bad, right, wrong. But it's about values. And when we apply our values and we find that we are in conflict, you have an ethical dilemma. And ethical dilemmas do not lend themselves to right and wrong discussions. What we have to do is understand what are the values that are underlying our positions and see if we can come to some kind of meeting of the minds, or at least agree to disagree. Okay? So when we talk about ethics, there are a couple of basic frameworks. This could be a whole afternoon's presentation. But there are a couple of different frameworks that I just want to highlight because I think they are most typically where most of us at least work generally. There's rule-based ethics, and rule-based ethics are just what they say. When I'm making an ethical, moral decision, I rely on a sense of what is right and what is wrong, and that tells me what to do. So, for example, a true pacifist will not bear arms under any circumstances, will not carry a gun, will not shoot at somebody or in any way seek to do them physical harm, even when their own life is being threatened. Because they have an absolute value about the sanctity of life and also of the immorality of them taking another life. And that, in their view, for a true pacifist, trumps everything else. Okay? Some of us might think that we have an absolute value around telling the truth, and some of it, we can interpret that in different ways, but for some people, telling the truth is always the thing to do, and you don't do anything but tell the truth. So I'm oversimplifying this a little bit, but that's how rule-based ethics go. You start with the rules, and you worry about the consequences later. And the other side is a more utilitarian or case-based or consequentialist way of thinking about things, in which you try to look at the implications of a perceived course of action, and you try to determine such things as what will bring the greatest amount of positive over the least amount of negative. Okay? So it's not ever absolute. Sometimes it's called the greatest good for the greatest number, but it also might just mean in my own life, I'm going to I'm willing to trade a little bit of the bad over here because I think that the good that'll come over here will outweigh it. And it's also, we tend to look for precedents in this kind of thinking. So what do if we can find out about other situations that are like this, how were they decided, and does that help us understand what we need to do? So it's a more flexible way of doing ethics. Probably in the medical center, it's more typically how we do ethics. But even when we take that kind of framework, we are still, from time to time, coming up against somebody's need for rules and how that informs the way that they're going about it. And we cannot say, no, you're wrong to be a rule-based person, therefore we're going to disregard your argument. We have to find another way to do about it. So then the question comes up, what makes pediatric ethics more problematic? And there are two reasons for that at least. One is it's very emotionally charged because children are our hope, they're our future, and we have a particular emotional attachment to children that makes facing hard things with them more difficult emotionally. For parents, certainly it does. Every parent expects to have a child and to have that child outlive them. Every parent has a child and has at least hopes that that child is going to be the fulfillment of some kind of dream that they have. And the children are our future, and we feel that at the hospital. And so the whole medical world is just organized around preserving and enhancing the life of these kids so that they can have the future that we believe that they deserve. And that makes it harder to look at consequences from an objective standpoint, whatever an objective standpoint might mean. The second thing that makes it particularly difficult is that the parents are the ones that have to decide on behalf of their children, at least up to a certain age. And that can really put them in a terrific dilemma. As they try to weigh out what do they hope for, what seems realistic, what's it going to mean for them to either let go of this child or to see this child through to an uncertain future. Because it's not usually the case that we're either talking about the child dying or the child getting better and going home and then having the life that everybody thought they were going to have. They may go home and have a much diminished life. What do we think about that? How do we think about that? So those two things alone make pediatric ethics particularly challenging. So I want to talk a little bit about some ethical issues here and to talk a little bit about consent, permission, and assent. Okay? Now, what do I mean by that? I want to make sure I have my right notes here. Okay. So the first thing we have to ask when we're talking about decision making is who decides. That's very critical. Wait a minute, I've lost my page here and I need to get back to it. Okay. Because on behalf of children, somebody needs to make a decision. When we're adults, we get to make that for ourselves, or we get to designate somebody else to make it for us if we're not able to do that. De facto, parents are decision makers for their children. And so they have to figure out what they think is the right thing to do. Now, this gets complicated if you've got parents who are not married or who are divorced, and they may have competing interests, but sometimes even within a marriage. I mean, just recently we had a case where one parent was ready to say, let's remove life support and allow this child to die, and the other one saying, absolutely not. By the way, who do you think prevails in a conversation like that?
The absolute not.
The absolute not, right. Yeah. When you get that kind of dilemma, then you decide on the side of life whether you think that's right or not, but if the parents have the right to decide. So you can imagine how tricky it gets. But normally, what we're talking about when we're making those decisions is best interest. What do we mean by best interest? You might start with, well, what would be in your best interest? How many of you have a living will or have appointed a durable power of attorney for decision making? Good. Excellent. If you haven't, you should. Because you never know what's going to happen, and you don't want people making decisions on your behalf that are not the decisions you would want them to make. And what that would normally consist of, and so when I talk to my wife about this kind of stuff, I try to be very clear about what I think would be in my best interest if I am in either permanent vegetative state or am incapacitated with no chance of recovery. I don't want to be kept alive on a ventilator. I don't even want to be kept alive with artificially delivered nutrition and hydration. I don't want any of that. I want to be allowed to die. That's what I think is in my best interest. You may have a very different take on that. And so it's very important to communicate that to those who are going to be in a position to make a decision for you. And if possible, write it down someplace. So best interest is what is most, how do I want to put this? Comports best with our own values about what our life ought to be about. The problem with doing this for children is you have to decide on their behalf what their best interest would be, what would be the quality of life that they might want to have. With an infant, it's impossible. An infant cannot have best interest because they have not yet developed any cognitive structure to relate to the world. So it's all projective. With older children, you can at least begin to get some sense of what's important for them and what's not important for them, and maybe begin to make some decisions on that. But still, there's a huge weight on the parents to have to make those kinds of decisions. So, what we then want to talk about are things like what is the difference between consent, informed consent, and permission. We want to talk about the parents and how they get into this. So we're going to take a few moments and do that. So let's talk a little bit about the competent parent. Now, what do we mean by competency? Competency means that you are of sound mind and capable of making rational choices on your own behalf or on behalf of someone else. And by definition, children are not competent to make those. Legally, they're not until they're 18. We can work with that in the teenage years, but there's that sort of formal definition of competency. But the more general one is having the capacity to make decisions on one's own behalf. Babies are never competent. That is, they have never been competent. And therefore all decisions must be made by the parent or guardian. Now, what do we mean by a competent parent? Sadly, this does not necessarily mean having all the wonderful qualities of parenthood that we would look for in a parent, with just really sober judgment and a good ability to balance a whole bunch of different kinds of things. It really has to do with, again, a more narrow definition. So if a parent, as often happens at Children's, is a minor, then her parent or guardian is the legal decision maker. She is considered not competent. We try to involve minor parents in the decision making and the biological father, if at all possible, but that is what we're talking about in terms of competence. The exceptions to that are when a parent seeks to make decisions that are generally viewed as not in the child's best interest. So we may have an adult parent who are making decisions that we think are really very, very troublesome. We will not allow them to make that decision. The classic case of that is the Jehovah's Witness. We work very closely with the Jehovah's Witness community at Children's, and because we understand that they do not want any transfusions for their children. We also know that we will do that if we have to, and we try to find every way to avoid doing that as much as we can. But the bottom line is these people are otherwise fully competent They're good, thoughtful, caring parents, and responsible in every way, but we make a decision that even though that competence exists, we do not allow them to inflict upon their children the implications of the choices that they would make for themselves. So, in general, there are two types of these decisions. There is surrogate decision-making and substituted judgment. Now, we make surrogate decisions on behalf of like a baby. Or if we have someone who was just never competent, maybe was born with severe impairments and never progressed beyond that. So in surrogate decision-making, we are just trying to do the best we can on their behalf because we never know what they really would have wanted. Substituted judgment is only used if a patient was once capable of having opinions or views relevant to the question, and there must be reliable evidence of those views. So we make a substituted judgment on behalf. How many of you remember Nancy Cruzan, the case of Nancy Cruzan? Woman was in an automobile accident, was left in a permanent vegetative state, and they wanted to move the life support. Well, she hadn't left a living will, and so that was denied, the surrogate decision makers. Fortunately, a little while later, a friend came forward who said, we talked about this all the time, I can testify to that. And once they had that information, then the parents were able to go back in and ask the hospital to remove her from life support. So, in either case, we're still trying to figure out what's in the best interest of the person.
What do you do with these things seem to be in the news every few months, where a child has a tumor and the parents do not want to undergo chemotherapy, the child undergo chemotherapy?
Mm-hmm.
How is that handled?
It depends. Surprise, surprise.
I should have known.
It depends. And here's across the board.
That's not a rule-based answer.
It's not a rule-based standard. It depends on if a treatment is the standard of care, what we would do for anybody with this condition under these circumstances with a reasonable expectation that it is going to produce a positive result, then we normally do not allow parents to make a decision not to do it, because that's putting the child at needless risk. They may be very anxious about it, they may have their reasons, but no. If it's a very iffy proposition, the outcome is uncertain according to whatever basis you want to make that on, we're more inclined to allow the families to make that decision. Okay? So then we get into consent. Now, informed consent is at the heart of much that goes on in ethics. And all of this comes out from the Nuremberg trials and the stuff that the Nazis did to these patients without any involvement on the patient's part. It also comes out of some cases in the United States where medical tests or studies were done on people without their knowledge and without their consent. And we have this understanding that no one may do anything to us without our permission, whether it's a routine appendectomy or whether it's the most complicated heart surgery imaginable, or whether it's going into a clinical trial to try some new medicines, or whatever it is, we have to be told what it is that they're proposing to do. So this is the informed part. And any of you here, who's had surgery? Okay? Hopefully something like this happened. I know it's sometimes a custom more honored in the breach than in the observance, but it's what needs to happen. So I'm going to tell you, this is what we're going to do. This is why we're going to do it. This is what we think the outcome will be. Here are the risks. And I will try to be clear that I believe the research literature shows it's minimal risk, but these are risks. And I also need to tell you what the consequences are of not doing the surgery. Okay? So that would be fully informed consent. And then your job is to is to give your consent, which means I agree, I accept, I understand everything you told me. Always a little dicey, but I understand that, and I give you permission. I'm signing here on the dotted line, and you may do what you need to do. Okay? So, the components of informed consent are the information themselves, the free and uncoerced agreement to do it, and if anything in that changes, then that changes the consent. Now, there are two others. There's informed assent. We often just talk kind of casually about, well, I'm giving informed consent for my child. It's not really what I'm doing. I can only consent for myself. Informed assent is what we give on behalf of others who have some capacity to participate in the process. So I've got my kid here, we've gone over everything, and we've explained it as best we can, and now I'm going to assent to this procedure on behalf of my child. And then informed permission is given on behalf of a one competent or never competent person. Okay? So that's, any questions about that? Because I knew this always takes more time than I think it's going to take. So I'm going to skip over the stuff on best interest because I think I've said enough about that. And I want to say a little bit about end-of-life issues and futility, which is a particularly difficult area when it comes to children. So end-of-life issues, I don't know if any of you are familiar with a thing called the baby doe regulations. Those were promulgated back in the Reagan administration. It all started with a case over in Indianapolis where a child was born with Down syndrome. The parents had a friend who was a pediatrician who said you shouldn't do anything for this child because it's just going to be a vegetable, and because the kid needed a surgery to repair a tear in the esophagus, and without it they couldn't eat. And so the parents agreed, and the child basically starved to death in the nursery. Well, word got out about this, and it stirred up a huge hue and cry. And out of that came a series of regulations that basically, at their core, recognized that handicapped newborns deserve the same protection of the law as any other handicapped person and should not be deprived of what all the rest of us would have access to. And in this case, this was a simple fix. And we also know that much more often than not, Down syndrome children can lead a pretty reasonable life, and a happy life, and a fulfilled and fulfilling life. So what these regulations also did was to establish criteria by which we could say, okay, under these circumstances, it would be okay either not to treat or to withhold treatment. Okay? And I'm going to say more about that in a minute. And so they set up some criteria that said if the treatment would be futile, you don't need to start it. If after you started it, it proves to be not working, you are free to withdraw it. In a way, the same kinds of criteria that we use in the adult world. So you may be faced with a very dicey treatment option, and you may say as an adult, I'm not going there. That's just way too much of a burden for me to bear, and I'd rather just to be allowed to die. Or you may say, well, let's get started. Let's see what happens. And after a little while, you realize you're not feeling any better, you're not getting any better, and you say, let's stop. And so they withdraw it. Okay? So, very simply, when we withhold a treatment, it says that means we are not obligated to begin a treatment that we believe will be futile or ineffective, and we are not obligated to accept a treatment that we don't believe is in our own best interest. And withdrawing is the removal of life-sustaining therapies which are deemed to be either no longer effective or which are merely prolonging the dying process. Now, I'm going to say something that may seem counterintuitive to you, and that is there are no moral distinctions between the two. People have a very hard time with that. But from a moral perspective, it's the same thing. You're looking at the futility of an action and saying no. It's emotionally harder once you've started something, especially on behalf of someone else, to back off from it. because we begin to feel like we're the agents of their dying. Which I don't believe we are, but I understand why people think that they are. So we've got just a little bit of time. I want to just say one more word about futility, then give you a case to chew on for a few minutes. And I'm skipping ahead here because I needed 3 hours. I'm sorry, Nancy. I needed 3 hours. We hear a lot about futility. Why are they doing this to someone? You know, why can't we just, nurses do that they ask that all the time. They're at the bedside and they're seeing stuff going on. Why don't these parents just let go? This kid's not getting any better. They don't understand. And futility is very tricky. First of all, there are two types of futility. One in which we say, well, we're not doing this because it would not make any difference. Just as a simple example, you don't give an antibiotic to somebody who's got a viral disease. Antibiotics do not affect viruses, okay? But people say, oh, can you give me a shot for that antibiotic? That's what I'm sorry. That will not work. So likewise, if we believe that the proposed treatment has no bearing, will produce no visible, desirable effect on this, we're not obligated to start it. But the problem is that futility can also rest in the mind of the beholder, just like a lot of this other stuff. So if you are a vitalist, if you're someone who believes that bodily life is precious and should be preserved at all costs, you want that ventilator kept on until their heart stops beating. So somebody else might say, this is not going to improve that life. This is not going to save that life. It's not going to return them to anything, any kind of life that was worthwhile. You say, I don't care. They're still alive. And it's certainly not my place to call that life to an end. So whose definition of futility do we then apply? And when it comes to children, again, and we're making decisions on their behalf, it's even harder because I'm going to feel responsible for what I do. Okay? So let me give you just a real simple case. I have it here somewhere. Well, I've got it on the slide. So you are the parent of a 15-year-old with acute myeloid leukemia. This is a pretty bad, not so bad in adults, but it's a pretty bad one for kids to get. It's very rare in children, and bone marrow transplant and the standard treatments don't tend to work very well. So we get very nervous when some kid is diagnosed with this. So now the kid has gone through several rounds of bone marrow transplant. They have not worked. And now they want to start clinical trials. Now, quick word about clinical trials. These are tests when they're testing new medications. And with clinical trials, there are 3 stages. And the first stage is all we're trying to do is figure out what's a safe dose. We have no expectation this is going to be curative. Second stage of clinical trials is then beginning to attest whether it's generally effective, whether it has any effect, and then it goes into further layers where you might move toward putting it on the market. So stage 1 clinical trials is not offered as a cure. You're making your kid part of a research project at the earliest stages of it. So that would be the first thing. I'm the doctor and I come to you and I say, well, we've exhausted all our normal possibilities, but we can offer these clinical trials. Would you be willing to have your child participate in that? So very quickly, what comes into your mind when you hear that?
It's no favor to the kid.
Huh?
It's no favor to the kid.
It's no favor to the kids. There's a chance it might work. Okay? There you go. Okay? Anybody else? Yeah.
Well, I suppose if the doctor tells you that the child has a very poor chance of survival, but you maybe it's the same sort of rationale that someone would use to donate organs. If my kid can contribute somehow to medical science to save another, maybe I do it on purpose.
That would be another way of looking at it. So you see, and again, you're talking about putting your child through this. You can volunteer for yourself based on what your values in life are. Or you say, heck no, I'm not doing that. But for a child, you are likely talking about putting them through some difficult treatments, which we know very little about. And so what's the value? I wouldn't want my child to suffer anymore. Yours is the one I think we hear more often from parents than not, along with that. It is very interesting that at least there's a chance. Something good, this may be the thing that actually starts working from the beginning. And so that's all I need to know. This is my child. And sometimes coupled with or instead the idea that it may not help my child, but that my child can help somebody else. So it's very interesting. So that's the first part of it. So you then have to decide. So let's say that you start the trials. Yeah.
Well, the first trial is also a dose finding. Right?
That's what I'm saying.
Yeah.
That's all it is. Yeah, we want to make sure it's a titration. It's like, okay, this is too much, this is too little, and we keep narrowing it down. And that's really what phase 1 trials are. It's just trying to find a safe dose for this. Never mind what else it might do. So now you've gone into a round or two of these, and then your child says, Mom, I've had it. It's a 15-year-old, remember, not of legal age, but has been dealing with this for quite some time. Pretty bright kid, and is saying, no more. I feel awful all the time. I have no life. Please, can we just stop? Then what do you do? Quickly. It's so easy. I mean, what goes into your thinking about that?
It's his life and her life. And
We talk about long-term and short-term.
And some,
prolonged suffering.
yeah, right. But do you allow the child to be the one to decide for him or herself? Because that's really, in a sense, what you're thinking about. At least you're letting the child's wishes now guide the conversation, or not.
But presumably you're doing that against the backdrop of the doctor saying the chances are not great.
Sure. Although, the research docs can hedge a little bit,
I was going to ask how much of the belief in the validity of the process is in the way that it's presented.
Exactly. Going back to informed consent. And I'm not saying people do a bad job of it, but docs really want to do this. This is how they learn. This is how we develop the treatments that make so many kids better. When I was first in chaplaincy, leukemia of any sort was a death knell. Kids got leukemia, they're going to die. That was it. You got a year. Now, a lot of these leukemias, not only they go in remission, they get cured. They go home and they live a life. How did we get there? On the backs of a lot of children who went through phase 1 and phase 2 and phase 3 trials. Figure that one out. So I know we're really at the end of our time, so I'm going to stop this part, and then we'll do whatever we want to do after that, okay? Thank you.